Hello, today's discussion is about functional constipation and Encopresis. Before going into constipation and specifically functional constipation, let us see normal frequency of bowel movements in infants. For those between birth to 3 months, if they are breastfeeding, we expect the mean number of bowel movements per week from 5 to 40, whereas the mean number of bowel movements per day is around 2.9. For those who are feeding formula, we expect around 5 to 28 per week because formula feed infants have a lower number of bowel movements per week and per day compared to that of breastfeeding infants. From those between 6 to 3 years, 6 months to 3 years, we expect around 1 to 2 bowel movements per day. Over 3 years, we expect bowel movement of around once per day and 3 to 14 per week. So this is a normal bowel movement of an infant between birth to 3 years based on their nutritional situation. Constipation is defined as a delay and a difficult in defecation that leads to distress. So there are 4 Ds: delay, difficulty during defecation, and which leads to distress. We classify constipation based on their duration and also based on their etiology. We say acute constipation if the duration is less than 4 weeks and a chronic constipation if it is more than 4 weeks. And also we say functional constipation if there is no organic causes, and we say organic constipation if there is some underlying causes. So functional and organic constipation can be acute or can be chronic based on the duration of the symptom. Functional constipation is associated with withholding behaviors. It starts from a certain change. At the time of onset of constipation, there might be a diet change in infants, there might be a minor illness, or it might be at the initiation of toilet training for toddlers or during starting school. Painful passage of hard, large caliber stool less than 2 times per week in the setting of withholding behavior is noted also. When we see the organic causes of constipation, we classify the organic causes into different causes. Those due to abnormalities of the colon and the rectum, those from spinal cord lesion, neuropathic lesions, metabolic problems like hypothyroidism, hypercalcemia, hypokalemia, uremia, systemic disorders, and drugs. Functional constipation is defined by a criteria. There is a diagnostic criteria for functional constipation by ROM4. ROM4 says presence of at least 2 of the following for 1 month in infants of less than 4 years of age. Those are 2 or fewer defecation per week, history of excessive stool retention, history of painful or hard bowel movement, history of large diameter stools, and the presence of large fecal mass in the rectum. The main difference between ROM4 and the ROM3 is ROM3 says 2 months duration, whereas ROM4 says 1 month duration. So it decreased to 1 month because it is important to diagnose early and intervene early, because as the duration progresses, the therapeutic outcome decreases. That is why ROM4 criteria decrease the duration from 2 months to 1 month. In addition, in toilet-trained children, the following additional criteria can be used as one of the criteria. At least 1 episode per week of incontinence after the acquisition of toilet skills and history of large diameter stools that may obstruct the toilet. When we see the pathogenesis of the functional constipation, first it starts with change of something. It might be change in routine, change in diet, stressful event, postponing defecation due to too busy or too early toilet training, or starting of school. They end up in voluntary withholding. This voluntary withholding causes prolonged fecal stasis. Prolonged fecal stasis causes reabsorption of fluids, which causes increase in size and the consistency of stool. This causes more pain during defecation, and it causes also additional voluntary withholding due to fear of pain. So this causes increased painful defecation, then additional voluntary withholding. So once it starts, it progresses. As I have said, more than 90% of constipation in children is functional constipation. But if we have the following finding on history and the physical examination, we should have to consider organic constipation. From this criteria, if there is passage of meconium after 48 hours interim nubo, if there is constipation starting the first month of life, if there is family history of Rhuskas-Sprung's disease, Revon stools, if there is bleed in the stool in the absence of anal fissure, failure to thrive, bileless vomiting, severe abdominal distension, abnormal thyroid gland, abnormal position of the anus, absent anal or cremasteric reflex, decreased lower extremity strength, tone or reflex, sacral dimple, tuft of hair on spine, gluteal cleft deviation, and the anal scars, we should have to think organic causes for the constipation. So if those things are available on history and physical examination, it might not be functional constipation. So it needs further diagnosis, further imaging, and further workup. Once we diagnose constipation, we should have to ask history and do physical examination to rule out organic cause for constipation. The physical examination of functional constipation often demonstrates a large volume of stool palpated in the suprapubic area. Rectal examination demonstrates a dilated rectal vault filled with Gaussian negative stools. Encopresis, sometimes called fecal incontinency or soiling, is a repeated involuntary passing of stool into clothing. Typically, it happens when impacted stool collects in the colon and the rectum, and the colon becomes too full and the liquid stools leak around the retained stool, staying underwear. This encopresis is common most of the time after the age of 4 years, after they achieved toilet training. Encopresis is divided into two subtypes: encopresis with constipation, or retentive encopresis, and encopresis without constipation. Encopresis with constipation is retentive one, whereas encopresis without constipation have some additional organic causes. Retentive encopresis is associated with complaints of difficulty with defecation, abdominal or rectal pain, impaired appetite are common. Children often have large bowel movements that obstruct the toilet, and there may also be retentive posturing or recurrent urinary tract infection. Whereas non-retentive encopresis is more likely to occur as a solitary symptom and have an associated primary underlying psychological etiology. Children with encopresis can present with poor school performance and attendance that is triggered by the scorn and the derision from schoolmates because of the child's offensive odor. In addition, the presence of hair tuft over the spine or spinal dimple or failure to elicit a cremasteric reflex or anal wing suggests spinal pathology. A tethered cord is suggested by decreased or absent lower leg reflexes. Urinary tract symptoms including recurrent urinary tract infection and enuresis can happen. Children with no evidence of abnormalities on physical examination rarely or doesn't require radiological evaluation. If there is no evidence of abnormality on history and the physical examination, other than constipation, we don't do any further evaluation. We diagnose functional constipation based on ROM 4 criteria and go to management. But if there is abnormality on physical examination history that suggests organic causes, we should have to go further imaging and also further workup to know the underlying cause. So in this case, specialized testing should be considered. For example, if we suspect hypothyroidism in addition to constipation, we should have to do thyroid function test and also should have to work up for hypocalcemia, lead toxicity, celiac disease, disorder of neuromuscular gastrointestinal pathology based on additional history in the physical examination that we elicit. Colonic transient studies using radiopaque markers or scintigraph techniques might be useful. Selected children can benefit from MRI of the spine to identify an intraspinal process, motility studies to identify underlying myopathic or neuropathic bowel movement, or a contrast enema to identify structural abnormalities. In patients with severe functional constipation, water-soluble contrast enema reveals the presence of megarectosigmoid. We do imaging or X-ray based on contrast enema, mainly barium enema, if there is severe functional constipation that's not responding to our management. So this barium enema reveals the presence of megarectosigmoid in the case of functional constipation. When we came to treatment of functional constipation, therapy for functional constipation and the Encopresis includes patient education, relief of impaction, and softening of the stool or maintenance therapy. Caregivers must understand that swelling associated with overflow incontinency is associated with loss of normal sensation and not a willful act. So when there is a distended colon due to functional constipation, there is decreased reflex that shows there is stool in the rectum, which causes overflow incontinency. It's not a willful act. There needs to be a focus on adherence with regular postprandial toilet seating and adoption of a balanced diet. The child should have to have regular postprandial toilet seating. The other is we should not start toilet training too early before the child is ready. Toilet training is recommended after 2 to 3 years of age, and it should be also appropriate one. Encourage to take more fluids, because if the child takes more fluids, it decreases the constipation. And high fiber diets such as whole grains, vegetables, and the fruits are helpful to relieve constipation. And also pharmacotherapy should be given if a child feels a criteria of functional constipation which is not responding to conservative management. Those pharmacotherapies are laxatives. We classify them into osmotic and stimulant. Osmotic one is PEG and lactulose, and sometimes sorbitol, and also stimulant is bisacodyl and glycerin. So polyethylene glycol and lactulose is the first line. Osmotic treatments are the first line, and stimulants such as bisacodyl and glycerin are only used when the first line fails. Disimpaction and the maintenance therapy is needed. If a child has impaction of stool, we should have to do disimpaction. And the disimpaction by PEG and lactulose for 3 to 6 days, if possible orally. If not, we can give suppository for infantis. After disimpaction, we should have to continue to soften stool by maintenance therapy. Maintenance therapy can be given by one of the following, but the osmotic one, polyethylene glycol, and the lactulose or sorbitol is the first line, and if they fail, we can go to second line. This maintenance therapy is generally continued until a regular bowel pattern has been established and the association of pain with the passage of stool is abolished. Therapy for organic cause of constipation needs treating underlying cause of constipation. This is all about constipation in the Encopresis. Thank you for watching.